Hi, good evening, everyone. At the outset, I would like to thank all of you for joining today on this beautiful occasion of Rare Disease Day. And we celebrate the 13th Rare Disease Day in India. And I am very happy that we all could come here today for the same. So, before further ado, I would like to invite Mr. Saurabh, who has been instrumental in organizing this event, this national symposium, for which we are very thankful for him. He has done tremendous work in helping children with rare diseases. And we now invite Saurabh to give the introduction of the speaker and tell a little about the Rare Disease India Foundation.
Good evening, everyone. I am Saurabh Singh, founder and chairperson of Rare Diseases India Foundation, RDIF. We are really very glad to see all of you here on the special occasion of first annual National Symposium 2022, starting from 26 February to 28 February, from 5:30 p.m. to 7 p.m. on Rare Disease Awareness Day. It was a 3-day event which was organized by Rare Diseases India Foundation, RDIF. I would like to thank Sanofi, Centogene, and LifeCell for supporting us for this cause. I wholeheartedly welcome all the eminent speakers, moderator, and the attendees who are watching us from different corners of this world. I also thank our strategic partner, ECMERI. RDIF is a patient advocacy group. It is established in 2019. This is a non-profit organization which works for the benefits of the patient to raise awareness about rare diseases in the country. As we all know that rare diseases are very few in numbers, and mostly it is genetic. Only 6% to 8% of population of India is affected with rare diseases, and 72 to 96 million people affected by rare diseases. There are many challenges in rare diseases. Either there is no treatment available, or the treatment is unaffordable by an individual, which generally comes in crores. Another challenge is early diagnosis of these diseases. It is also one of the major challenges in rare diseases. Lack of awareness about rare diseases, including patients, medical fraternity, and general public. Government does not fully support in these diseases. Families are bound to watch their person dying every day. We all know that in the month of March 2021, the government of India has formulated a revised rare disease policy, but that too is not very much effective, especially for group 3 diseases, which includes lifetime treatment, but cost is very high. To discuss in detail about these issues, today we have the best speaker of India who are treating rare disease patients. First of all, I would like to welcome our keynote speaker, Health Minister of Jharkhand, Honorable Banna Gupta ji. Our another speaker for this symposium is Member of Parliament, Honorable Ajay Nishad ji. I also welcome our another speaker, Dr. I.C. Verma from Sir Gangaram Hospital. He is also one of the best genetician in India. He is known as father of genetics. We have a panel discussion also after this speeches. Dr. Madhulika Kabra, who is the head of department, AIIMS New Delhi, he is the panelist. Dr. Radha Ramadevi from Rainbow Hospital, he is also one of the panelists. Dr. Ratna Duapuri from Sir Gangaram Hospital, Dr. Sudha Phadke from SGPGI Lucknow, Dr. Ashok Gupta from JK Lone Hospital, Jaipur, Dr. Priyanshu Mathur from JK Lone Hospital, Jaipur. They all were talking about the rare diseases. Today, we also have two more speakers. Mr. Anil Raina, he is the head of Sanofi India and South Asia. And our another speaker is Mr. Prabhat Ranjan Deen, he is the senior journalist. And last but not the least, I most welcome our young and dynamic moderator, Dr. Veronica Arora from Sir Gangaram Hospital. So the purpose behind organizing this wonderful event is one and only to spread awareness about rare diseases among the patients, family, general public, health fraternity, and the decision makers. Over to you, Dr. Veronica.
Thank you.
First of all, I also want to introduce Mr. Ajay Nishad, who is the Member of Parliament. I think he has joined. Honorable Ajay Nishad. No, I think we have lost him. So We have a video because I have got a call from Health Minister Jharkhand because due to some assembly discussion, he is not able to join. He has sent his video. So I would request our IT team to please play the video of Honorable Health Minister of Jharkhand. He has given some message.
रेयर डिजीज के उन्मूलन के लिए आज जो एक सिम्पोजियम का आयोजन किया गया है और इतने बड़े मात्रा में चिकित्सक और चिकित्सा पदाधिकारी और समाज सेवी प्रबुद्ध लोग विभिन्न कंपनियों के पदाधिकारी जुड़े हैं। मैं आप सभी लोगों को इस केयर फॉर रेयर उन्मूलन अभियान की बहुत शुभकामना देता हूं और आशा उम्मीद करता हूं कि हम सभी मिलकर इसके उन्मूलन की दिशा में काम करेंगे, क्योंकि इसमें एक बहुत ही बृहद पैमाने पर जो है अर्थ की जरूरत पड़ती है और उस अर्थ को जुटाने के लिए हम सारे लोगों को इसमें पार्टिसिपेशन करना चाहिए। मानवीय दृष्टिकोण पर अपने सामाजिक और धार्मिक और मानवीय दायित्वों का निर्वाह करने के लिए मैं बहुत धन्यवाद देता हूं भाई सौरभ सिंह को। उनकी जो है उनकी संस्था इसमें बहुत बेहतर काम कर रही है, जो रेयर डिजीज इंडिया फाउंडेशन के नाम से संस्था चलाकर लोगों के इस कठिन बेला में उनके सहायक साथी के रूप में काम कर रही है। मैं पुनः बहुत धन्यवाद देता हूँ। उम्मीद करता हूँ कि हम सब मिलकर क्राउड से भी डोनेशन जनरेट करेंगे, CSR वगैरह सभी लोगों को मदद लेंगे और जो प्रबुद्ध और अच्छे लोग हैं उनका भी सहयोग लेंगे। और मैं समझता हूं कि इस तरह की संस्थाओं के द्वारा यदि ये रेयर डिजीज पर काम किया जाएगा तो हम समझते हैं कि एक मजबूत व्यवस्था लागू होगी और उसमें जो हमारे मरीज हैं उन लोगों के जीवन को चुस्त दुरुस्त और स्वस्थ करने की दशा में हम कारगर रूप से कदम उठाएंगे। और मैं ये आपको विश्वास देता हूँ राज्य के स्वास्थ्य विभाग की ओर से कि जब कभी भी हमारे स्वास्थ्य विभाग की आपको आवश्यकता पड़ेगी हम आपके लिए बिल्कुल मजबूती से काम करेंगे। पुनः एक बार आप लोगों को इस सिम्पोजियम के सफल आयोजन के लिए बहुत बहुत धन्यवाद देता हूं, बहुत बधाई देता हूं और उम्मीद करता हूं कि आप इसी तरीके से दिन दुगनी चौगुनी मेहनत करेंगे। बहुत बहुत धन्यवाद। सभी लोगों को मेरा जोहार और प्रणाम।
Thank you, Health Minister Banna Gupta ji, for giving your speech, wonderful speech about rare diseases. And I have the Member of Parliament who is trying to connect. I don't think he has joined now. So he will join middle of the session. So we should start. Veronica, I think.
Yeah. So, so let's start the program now. And now I think the choice of communication can depend on the panelist and the speaker. You can decide to speak in Hindi or English. I think that is whatever we prefer. So I'm just going to share my screen now. So I welcome you all to the celebration of the Rare Disease Day organized by the Rare Disease India Foundation. So it is my privilege and great honor to introduce Dr. I.C. Verma, who's a professor. He's currently an advisor and senior consultant at Gangaram Hospital. He's a fellow of Royal College of Physicians, London, American Academy of Pediatrics, National Academy of Medical Sciences of Delhi. He has been working in the field of rare diseases over half a century. He established the WHO Collaborating Center in Genetics for Developing Countries like at AIIMS, New Delhi. He was the president of Indian Society of Inborn Error of Metabolism, Society of Fetal Medicine, Indian Society of Human Genetics, and Indian Academy of Pediatrics, Delhi branch. So has been a president of almost all societies, genetic related society in India. He also has founded Journal of Fetal Medicine, and his contribution to rare diseases is like none other. Thank you so much, sir, for joining us today. And I now invite you for your speech. Thank you, sir.
Well, friends, my first issue that I would like to discuss is the word rare. I think this has caused a lot of confusion. So people think rare is really like ultra rare, affecting only a very few people, which is far from wrong, right? As you know, in the world, there are 400 million people suffering from rare disorders. And in India, we have almost 70 to 84 million people suffering from rare disorders. So it's not a small number. And in fact, it is 5% of these disorders which constitute 80% of the total burden. So the burden that we are talking about, like disorders like Duchenne muscular dystrophy, like spinal muscular dystrophy, they affect quite a large number of people. We get patients almost in every OPD, we will get one patient of a Duchenne muscular dystrophy or a spinal muscular atrophy or some other rare disorder. 70 to 80% are genetic. So the geneticists see much of them. But even the other specialties like neurology, they also see many of these patients. The problem, of course, is that there are 500 drugs already in the market for the rare disorders. And the international organization has laid down that by the year 2027, they want to see 1,000 new disorders having treatment. So they're really working very hard on developing various treatments. So 50% of these disorders are actually life-threatening. That means that they may kill the patient if you don't give the proper treatment. So as you see that the burden is quite high. The problem which happened in India that most of the countries, the definition is the starting point. How many people you estimate? So the number that they have left it variable for each country. In the US, it was anything which the total number is less than 200,000 would be called a rare disease. So now 200,000 is not a small number. In India, with a population 4 times of US, we recommended that we should use the figure of 300,000. So tell me now how many diseases actually there will be less than 300,000. So all these disorders, so there are quite a large number of people who get affected with this disorder. Now, the main issue when we start discussing comes up that what is the frequency? What is the frequency of these disorders? And I think since we have as Dr. Verodi was saying the other day, you need this newborn screening to give you the exact incidence. But I think now the new technologies, the new generation technology, the next gen sequencing gives you an easy method of defining what the total number is by the carrier frequency. If we can find the gene frequency, I was looking at the Hardy-Weinberg principle that if a gene frequency is of 1 in 300, the incidence of the disease will be 1 in 100,000. So most of these disorders are more than this. So you need to examine about 1,000 exomes to get the real frequency of these disorders. So this is what I plan to do, at least to take up this and try to develop backwards from the gene frequency and get to the frequency of these disorders. Now, major issue, I think we have to prioritize the diseases. See, we haven't, unfortunately, we have not succeeded in letting the government in doing its duty. I think it's their duty to give some aid to these people and not to let them die. And so we must, I think, as a group, if we get together, I see no reason why the ministry should not relent and should support this rare disorders by financial aid. Because certainly we are not a poor country. I don't think anybody walking around in India will call us poor. So I think the second issue, of course, is we must join together, work together. I think that's my message. That work together and let's get something going. We must get the program started. Thank you.
Thank you so much, sir. Your words are always inspirational for us, and we shall all thrive to work together for these children and get them a better quality of life. Now we will move on to our panel, and I would at first want to just introduce our celestial panel, which we have, who are all experts in the field of genetics. We are very thankful for to all of them to join, and I would also request IC Verma sir to opine and comment whenever he feels necessary. So first, I would like to welcome Dr. Radharama Devi ma'am. She's a consultant senior pediatrician and clinical geneticist, president of ISIM, and currently affiliated with Rainbow Children Hospital and Reddy Institute of Life Sciences. Her areas of special interest are IEM, newborn screening, and she has won various awards and accolades, has numerous more than 150 publications, and was awarded the top 10 women in medicine in 2007. And the Sandor Oration Award was received by ma'am in Pune in 2019. And she also received the IC Verma Outstanding Researcher Award in 2018. And she started the first large-scale newborn screening in India. Welcome, ma'am. We are very happy to have you. Next, I would like to introduce Dr. Madhulika Kabra ma'am. She heads the genetic division of AIMS at present. She has more than 250 publications to her name. She won the Dr. IC Verma SAIMG Outstanding Researcher Scientist Award, and also the Dr. IC Verma Lifetime Achievement Award in ISHT 2016. She's a member and head of various committees and technical expert groups, and we are very thankful, ma'am, towards for your presence today. Also now we would like to invite Dr. Shubha Phadke ma'am, who is the professor and head Department of Medical Genetics, SGPGI Lucknow. Her areas of special interest are pre and postnatal dysmorphology, genetic diagnosis, psychosocial issues in genetic counseling, for which ma'am is an expert at. Her experience in medical and pediatric education is more than 30 years. She has almost 300 publications, and she's even written a book in genetics for which we all as students follow. She's the founding president of Society of Indian Academy of Medical Genetics and editor of Genetic Clinics, which is the newsletter which is followed throughout India in genetics. She also has various awards to her name. We welcome you, ma'am. Next, we have Dr. Ratna Duapuri, who's the professor and chairperson, Institute of Medical Genetics and Genomics at Sir Gangaram Hospital. She's an MD Pediatrics and DM Medical Genetics from SGPGI Lucknow. Ma'am has more than 150 publications to her credit. She has won the Dr. IC Verma Outstanding Researcher Award in 2019, the Dharam Veera Award for Excellence 2010 in recognition of her meritorious work. She's a member and one of the pioneers of the Undiagnosed Disease Network International of NIH USA. And she also won the Young Investigators Award in Tokyo, Japan 2006, and member of the panel of expert of WHO Collective Global Network for Rare Diseases. And we like to welcome you, ma'am, and we are very happy that you're part of this program today. Next, we have Dr. Ashok Gupta, who's presently a senior consultant and professor in J.K. Lon Hospital and SMS Medical College and Hospital. Sir is a part of many scientific activities. He's conducted international conferences on pediatric rare disease and rare disease celebration. He was invited as the national speaker by the government of Israel to talk over national policies of rare disease in November 2019. He set up a rare disease center in one of the regions where we would not think it was so easy to develop. He was nominated as one of the members of National Policy Advisory Committee for Rare Disease, Government of India, and he's a chairman of National Committee for National Policy for Treatment of Rare Disease of Rajasthan, and one of the board members from Asian Alliance of Food Allergy Tokyo. We welcome you, sir, and we wait for your expertise and comments. Finally, last but not the least, we have Dr. Priyanshu Mathur, who's the Consultant Pediatric Rare Disorders Associate Professor, Pediatric Medicine, SMS College, Jaipur, and he's a former visiting consultant, Emory University School of Medicine, Atlanta, USA. He has done MD Pediatric Medicine and Fellowship in Metabolic Genetic Disorders and Newborn Screening from Emory University in Atlanta. So welcome, Priyanshu. We are very happy that you're part of this talk. So without wasting further time, I would like to first invite Madhulika ma'am to answer one of the important questions that in view of your experience with rare disorder, kindly give us an overview of the rare disease policy and how are the disorders really classified and what made the policy bearers really classify the disorders like that, and what is the role of the centers of excellence in these disorders, and how can the referral systems be put in place, and how can people with rare diseases requiring transplant be helped by rare diseases? Is there a way, and the amount of capping on money we have on each transplant, how can that be decided? So ma'am, I think you would want to share your...
Yeah, so there are a few slides, Veronica. I'll just project them just for better understanding. So I'll share my screen. And is it visible? Is my screen visible?
Yes.
Yes.
Okay. Thank you very much, Saurabh, for involving me in this, and Veronica for preparing the panel very nicely. So I requested her to, I'll answer my questions in the beginning itself because there are some other commitments, and I bring you greetings for the Rare Disease Day. So I have to tell you briefly about the rare disease policy and the diseases covered and the networking from the centers of excellence. So you are all aware that the policy was initially declared in May 17 and was retracted because of logistic issues, and was declared again in March 21. The new policy has a more holistic approach, and there is some clarity on funding for therapies, though there are still many issues, as you all know, and the efforts for implementation are going on. So the directions which the policy includes, first and foremost, is integrated and comprehensive preventive strategy, which would include awareness, counseling, pre and postnatal screening, and prevention of births of affected children by prenatal diagnosis. Then important direction is to enable access to affordable healthcare to patients of rare diseases, and then public health hospitals being a state subject, there's coordination and encouragement of the state subjects to include rare diseases in their health armamentarium. So this is the three groups which Veronica was asking about. See, initially when this classification was done, primarily, if you remember, the first policy was declared as treatment of rare diseases, actually, for treatment of rare diseases. And the focus was more on the treatment aspect. So keeping the cost in mind, this was an arbitrary division based on the cost involved in treating these three groups of disorders. So the first group, which is treatable under the Rashtriya Arogya Nidhi, is a one-time treatment. So that is for transplants. So this would answer your question, Veronica. For rare diseases, the cutoff for transplant money has been increased to 20 lakhs. That's maximum. And transplants include all kinds of transplants. And earlier, this RAN was actually restricted to people below poverty line. But for rare diseases, it has now become open. It is not that you have to be below poverty line only to get the benefit. So this is a one-time treatment, and full support is available for this particular group of disorders. The second group, which has lifelong treatment, but the cost is not that much. The responsibility for funding these disorders is for the state government. And this includes very important disorders like inborn errors of metabolism, small molecule diseases, which require special medical food products, and other disorders which require like growth hormone therapy, pancreatic enzyme therapy, for cystic fibrosis, bisphosphonates, immunoglobulins, and so on and so forth. So here, some state governments have started taking care of this, but then there's more liaison required between the central and the state government, because I mean, the state governments really need to understand how it would work. And then the final one, which is the most difficult group, is the group 3, where you have lifelong treatment and the cost is exorbitant. And you are all aware this includes the lysosomal storage disorders, neuromuscular disorders, and some expensive treatments, and many more are coming up. So, and this has been, the funding was thought to be through the voluntary crowdfunding, through CSR, involving various PSUs and multinationals and so on. So it is a dynamic process, and multiple times there are questions that, is this the restricted list of diseases which have been listed here? It is not so. Any disorder which is rare and which has any kind of treatment can be considered for funding, and the application has to be sent to the Central Technical Committee of Ministry of Health and Family Welfare. This is the portal what I was referring to, and all the details are available, how to donate and what patients have already been enrolled and what will be the cost and benefit for that treatment. The centers of excellence as of now identified are 8, all in the public sector, covering India as much as possible. And definitely these are not enough, and more are to be added in a phased manner. And there has been many discussions regarding this within the ministry, and I'm sure many more centers would be coming up very soon. So the jobs of these centers, apart from treating these patients, is education and training, screening, diagnostics, in all areas, prevention, research, and research primarily in the area of low-cost diagnostics and therapeutics. And all these centers have their own account for receiving funds for the rare disease treatment through the portal. And each center has got a group of members who are working locally, and then all the centers of excellence work together. Now, Veronica, you also asked about the networking. So the issue is that when the rare disease policy, the portal was open, it was not clear how the patients will be sort of applying for it, and it is still undergoing revisions. So as of now, the method is that nearest center of excellence, the patient can be referred there, and the applications as of now are uploaded by the center of excellence only. And then it may be discussed within the Central Technical Committee, all these applications, and then finally funding. So, and then some, applications are directly coming to the Central Technical Committees also. And then they are again viewed by the members, which includes members from the centers of excellence as well. So this is what I had. And if there are any questions related to this, I would be happy to answer. Thank you very much, Veronica.
Thank you so much, ma'am. Ma'am, there are like 1 or 2 questions on the Facebook which says that what is the approximate time? I mean, I think patients want to know, and what is your experience with providing a bone marrow transplant actually at the level of the centers of excellence? How much time does it take? For example, if we have a child with MPS 1, so the whole process, how much time would it take, and what are the various challenges the patients would need to go through?
Yeah, so this is a very important question, because for disorders like lysosomal storage disorders, not many centers are offering bone marrow transplantation. So the first thing is to have a match, and you know that a sibling match and who should not ideally be a carrier. And after that, the conditioning regimens are different at different places. So if you have a matched donor, then the process is quicker. But if you do not have a matched donor, at least that experience we have with us, that we have one child who's waiting, and we are searching for a donor through the registries which are available, and that becomes much more expensive than if you have a donor yourself. So it depends on the hospital and the availability of the donor, that how long it will take. But then once the clinician recommends that this is to be done and recommended, the money from RAN, there's a separate RAN committee at least at AIIMS, and the clearance comes from them.
Okay, ma'am. So the timing really depends on how much time it has. So, ma'am, another question that was there on Facebook Live was the ethics. It is a little unrelated to this, but the ethics which are to be followed when we are doing maybe a PGD for thalassemia and for an HLA matched siblings, and could such children also be a part of the Center of Excellence? I think anyone in the panel can also.
Yeah, I mean, this is an issue, and we face this. Like, some of the parents would like to have a HLA matched child only because they want to treat their child with thalassemia or any other disorder. So this has ethical issues, and some parents would say that they would continue with the pregnancy even if the baby is not HLA matched, but some would say no, because we already have 3 children. We are just having this pregnancy to save other child. So it's a very difficult and tricky situation. And I don't think there are any guidelines on this. Maybe sir knows about it, because there are guidelines for other things related to, say, transplants and IVFs and things like that. But I'm not sure if there are any specific guidelines for this. Sir?
Well, I don't think India has any such a guideline for pre-implantation.
Yeah. Okay. Thank you.
Thank you. Thank you so much, ma'am. Does anyone else would like to comment on the HL issue or ask ma'am any question among the panelists?
Can I ask one question?
Yes, ma'am, please.
Madhulika?
Yes, ma'am.
Is there any priority in sanctioning those patients who have applied under the group 3? Suppose you have a patient for ERT and a patient for SMA. So how do you differentiate? How is the patient gets the sanction?
Okay.
Is there any priority in these cases?
Okay, ma'am, this is something very important actually, and we have been discussing about this, that as of now, there is not enough money in the portal so that we can fund even one patient. But then this was discussed, and as you rightly said, whatever number of patients are there on the portal, we will need to probably list them and prioritize it. Who's the one, what is the amount of money which is available, and who's the one who's going to benefit best. And then it can be a decision taken by the whole committee. Maybe all the members can sit together and prioritize. So I think this is a very, very important question, because some children are likely to respond, and then some children have emergency. Like somebody like SMA1 would be an emergency. So for this, in fact, we do not have any written guidelines as of now, but this has been discussed multiple times, and I'm sure we will come out with something on this, ma'am.
Are there any guidelines given by the center to the states with regard to funding for group 2 disorders?
Ma'am, I am actually not sure, though this was being discussed yesterday also in one of the meetings. The states have been informed about, they know about the rare disease policy, but then I think it seems that the connect between the states and centers, barring few states, is not really good. And this was also discussed recently, and then more involvement of the states has to be at a very, very larger level. And involving in the states, there are many centers within the states which are actually working in the area of rare diseases. I think Ministry of Health would be working in this area. But you are very right, ma'am. The connect between the centers and states has to be really, really strengthened. Then only we'll be able to help all the families.
Because until now, not a single patient in group 2 has any benefit.
Yes, ma'am. For group 2, ma'am, I think the people probably do not know also that somehow, because focus is on group 3 all through.
Yeah, all the time. Group 1.
Yeah. So I think we need more dissemination of this information, because we know many of our parents are not able to afford diets and other things. So I think with time, we need some celebrity to increase awareness about this, about our, whatever we plan to do. So I think it's really important. Somebody who knows any celebrity should sort of catch hold of that person and have some dissemination of this particular cause. Okay, thank you.
Can I say something?
Yes, Shiva.
Regarding group 2 disorders, recently last week for 2 patients, we decided to approach NHM and our social worker will be following, trying to see if they are aware and how they would like to fund, because the money is not much when we think of ourselves or the government, but for the patient, that is a quite large amount. So let us see, because all the questions which we discussed are because the things have not progressed. So if we get one case for SMA, one case for Gaucher funding, and then similarly multiple cases for group 1 and group 2, then I think initially pursuing will be needed, and then that will help in setting up the system.
Definitely, Shubha.
So that's how I think.
Yes, definitely.
Okay. I think, ma'am, Dr. Priyanshu has one question which we can take, and then we can.
I can log off. Yes.
Dr. Priyanshu, do you want?
Hello, good evening, Madhulika ma'am. I have a
Good
question.
evening, yeah.
I have a question. If we want to include JK Hospital in the list of Center of Excellence, what is required from our end?
Priyanshu, this is, I am not able, I'll not be able to answer this because this is being done to the Ministry of Health. And in yesterday's meeting also, Dr. Ashok Gupta was there and he raised this issue. There are many requests regarding this. And I think MOH is trying to find the whole procedure for this, and they would be able to help you out better. Okay. Thank you very much. Thank you.
Thank you so much.
Thank you, Veronica. I'll just log off. Thank you, everyone. Have a good, very nice day.
Thank you, ma'am. So we shall move on now. So the next question that I would ask is to Radharama Devi ma'am about that you have a vast experience of managing metabolic disorders and you have been a pioneer in newborn screening as well. Please comment about your experience in managing disorders with group 2, one with the whole rare disease policy thing and also at a private level and how many patients can really afford it. What steps do you think can be taken by the government to enhance the availability of these drugs, and how can the center support the state better for this? Also, ma'am, another question sir really wanted you to talk about was about newborn screening and the potential of newborn screening for lysosomal storage disorders and where we are at in those. Thank you, ma'am.
Can I share my screen?
Yes, ma'am. I will just stop sharing my screen and yeah. Yes, ma'am. Please go ahead.
Yeah. Is it visible?
Yes, ma'am.
Thank you very much, Veronica, for giving me the opportunity today to speak about my experiences with regard to metabolic disorder, inborn errors of metabolism. And these are the greetings from Rainbow Children Hospital, Hyderabad. And this is one of the tertiary care hospital. And we do get a very large number of interesting rare diseases, including inborn errors of metabolism. And this is the place where we are developing the management of rare diseases, especially the inborn errors. And we have been training some of the fellows in the field of management of an IEM. With that, I'll just go to answer your first question with regard to treatment of treatable metabolic disorders. So when we talk of these metabolic disorders in the initial phase, our experience was quite limited in India because many people, even the physicians, there is lack of exposure on this subject. And number two, there was actually people never encouraged to start treating these conditions because of the non-availability of the medical formulas for these disorders. And number three, that the cost of importing these foods are very high. So this is the reason why the field of inborn errors have not developed in the beginning. However, over a period of time, the situation has improved and more and more number of physicians are showing interest to manage cases and also diagnose them. And this is mainly because of the availability of the locally available medical formulas. So this is one good thing that has happened in between 2012 to 2015, where some companies have started producing the local diets. Of course, we need to improve the principles of diet management, not only among the dietitians. I always suggest even the pediatricians should be able to make the diets for these patients along with the dietitians, because in many places you don't get dietitians, especially if you go to the districts and the local and the villages, you don't have dietitians, but it is the pediatrician who has to make these diets available, formulated for these patients. I'm sure pediatricians are aware of how to make a diet, because there is a training given to pediatrician during their course with regard to nutrition. So with this brief introduction, I just say that the aim of management includes that you need to maintain a balance with regard to the biochemical parameters when you are treating a patient. And this treatment should prevent the accumulation of excessive toxic metabolites in the body. And you need to achieve, while treating these patients, normal growth and development, and ensure that the diet is palatable to the child and flexible and acceptable. And then we need to do periodic evaluation of the patient, monitoring the levels of the metabolites in order to adjust the dosage. So these are the dietary management guides which we follow when we are treating a child. So my experience, this is all my experience with the locally manufactured special diets for IEM, especially of the amino acid disorders, the organic acid disorders, are the main ones, the small molecule diseases that we do treat with medical formulation. So what are the observations that we have made with this? So the first and important observation was that the response to dietary therapy is closely related to the age of diagnosis. See here, earlier the age you diagnose, better the response to treatment. And number two, and the other important thing is the extent of the existing damage to the organs. If suppose there is no damage occurred, the response to treatment is very good. But if there is a damage already occurring to the nervous system, the response may be not that good. So the second point we observed is that we obtained best results when initiated treatment following newborn screening. So here I would like to answer the question of newborn screening. And this is one of the most important public health programs that should be initiated in our country because of the high prevalence of treatable metabolic disorders. And this newborn screening to be done to each and every baby born and to make a pre-symptomatic diagnosis of inborn errors of metabolism, because as I've already pointed out in my first observation, that the response depends on the age of diagnosis. And the other observation which we have found was that there is a genotype correlation to the diet therapy. This is especially so when you have diagnosed methylmalonic aciduria, where the mutation, the type of mutation helps you what sort of a treatment that is to be given. If it is a MUT, you need to be very strict with the diet and diet has to be followed. And if it is due to MMA-A, due to the cobalamin deficiency, B12 deficiency, then here it is the supplementation of B12, which is more important than a strict follow of the diet. So like that, you need to have a relation to the genotype. And in PKU, when you are treating a child with PKU, not responding to diet therapy, you need to look for BH4 deficiency, and then you look for that mutation. And that is where your the management alters based on the genotype. So the fourth observation is that the results need to be recorded in terms of tolerance to the diet. Say, suppose if the child is not able to tolerate the diet, then the response to treatment is not good. And then compliance is important. and the blood levels of the metabolite, the intellectual development, growth, and general well-being. So these are the things that need to be monitored, and a good growth and development, good intellectual development indicates a good response to the treatment. So these are the things which we have observed in managing these patients with the medical formula diets. And just to say that how the experience has passed through over the period of 12 years in the management, when I calculated the response during the period of 2009 to 12, there was a high mortality of IVMs. This is due to lack of medical diets and lack of diagnostic facilities. Between 2013 and 18, we did observe a better response and acceptance of the diets, and there is an improvement in the morbidity following the use of these medical diets. And better observations are these: 2019 and 22, there is an improved mortality and morbidity. Many children are leading normal life, almost near normal life, with the diet management. Here, acceptance has become more and more, and awareness has become more and more, and then easily available medical diets. We have two more companies who are doing the, we are giving the diets for the people in India. So as we go forward, there is an improvement in the management of IEMs. So the other important thing, we are also able to prevent the recurrence because of the development of prenatal diagnosis in these cases. So this is also gaining momentum, especially in areas where people, where these patients are concentrating in the management. So this will further improve if newborn screening is introduced and government support to help the families financially to meet the cost of treatment. So newborn screening is the most important thing that needs to be introduced as early as possible in our country in order to manage these cases effectively. So there, so I just give one example of a group of disorders where the response to therapy with the diet, taking glutaric aciduria as an example. We have about 28 cases we have followed. And of that, we also found 16 of them had already developed neurological damage. And this has occurred in the beginning of this starting of the treatment. And we have 12 of the children who are normal on follow-up. So we have got a high neurological morbidity due to delay in the diagnosis, absence of newborn screening, and not thinking of an abnormal metabolism in a child with dystonia or macrocephaly. So the response to treatment, as I put it here in my graph here, the earlier the diagnosis, the response is good. And this is the child diagnosed early, is now 6 years, absolutely normal, going to regular school. As compared to this wheelchair-bound child who was diagnosed late at the time onset of dystonia, there's no point in, even if you metabolically control this child, the dystonia and neurological damage cannot be prevented. So the good response with newborn screening is indicates the need for newborn screening. And this is the one condition which should not be missed in the neonate, as early intervention gives 100% success in management. So this is one example to show the effectiveness of these metabolic diets in these children, and this will further improve if you have newborn screening. So what I recommend here is that the early diagnosis of inborn errors is very essential to prevent morbidity and mortality. You need to have a high degree of suspicion for a metabolic disorder when managing a sick infant or a child or an adolescent. High risk families you should consider, and consanguinity, families with consanguinity, please screen all the babies. You must make to screen newborn in these cases, and then introduce newborn screening. And the quality labs you need to have, and learn to interpret results by yourself, and learn to manage with the special diets. Most of us have knowledge regarding nutritional guidelines in pediatrics. And please develop a positive counseling and proper advice for prevention through prenatal diagnosis. So the moment to feel happy, one of my patients with MMA, the boy is, though short, is going on for growth therapy. And can you believe that this boy is selected to participate in Paralympics in cycling? So an 80-year-old girl is a ghazal writer and is now getting married. A 20-year-old girl is going to become a doctor. She wants to become a doctor. And these are the moments which you feel happy when you treat these babies early in their lives. So the management, these are the 5 P's: parents' acceptance, professionals to show interest, proper time to do newborn screening, proper follow-up of treated patients, prenatal counseling for the next pregnancy for the couple in order to avoid recurrence. So these are the 5 P's that are very important. And these are my experience in these cases. And answering your other question of the availability of drugs and the role of government, I just put there many drugs that are specific for certain metabolic disorders, and they are not available in the country. For example, the tetrahydrobiopterin, the orphanin, dichloroacetate, simple drug like dichloroacetate, or even sodium benzoate injectable form, and they are very expensive when we import them. So government role here, that there is a political will is very essential to make this happen. Where there is a will, there is a way. And by exempting customs duty on these drugs and maintain drug availability in the country, then we can keep some of these drugs in the country. Then there should be financial incentives to be given to the pharma companies to make research and develop these drugs within the country, as we have developed the medical diets, and we have the know-how to do. I always feel bad when I hear that tetrahydrobiopterin is made in Hyderabad, but it is not available for us. So we can make these drugs in this country, provided government gives support to prepare these drugs. A special insurance, I suggest to have a special insurance claim for reimbursement of group 2 disorders, since most of the states are not interested to give financial assistance to these patients. So what they can have is an Affordable Care Act and prohibit the discrimination of pre-existing conditions. And there is no annual or lifetime limits, expand the Medicaid, and requires private insurance to cover it. So government, this should be introduced for all these group 2 disorders, a special insurance claim with these following principles. So this is your second question. And this is the third question, which I would like to answer. How center can help the state? The center should cover this, what I feel maybe probably through National Health Scheme, taking priority in implementing the scheme, as these disorders are life-threatening and with high morbidity. Leaving the responsibility to the state, I'm sure this may not be implemented in certain states. Example, my own state. Or the government should mandate the state to implement the system of reimbursement through the health schemes and provide funding to the to the health department of the state from the center to implement the group 2 reimbursement. So these are some of the suggestions which I thought may be useful to the government to see that this is effectively implemented to benefit the patients. Newborn screening is one thing which we should all strive to see to be implemented in this country. And maybe we can have certain panels to be included, especially those with high morbidity and mortality. And with regard to the screening for lysosomal storage disorders, I feel, although we can do it, but until we are very, very sure that we are going to treat that baby, then only we go for the newborn screening. There is simply doing newborn screening and identifying them and giving them no treatment. I think it may not be that helpful for the families. When we are sure of giving treatment, we'll do the newborn screening. So today we are sure of doing treatment for the metabolic disorders. We do it for that first, and then we go for the subsequent ones. So this is my idea, and thank you very much for giving me this opportunity, and thank you. I will be ready to answer any questions.
Thank you so much. Thank you so much, ma'am. That was very enlightening, and all the ideas you gave about the center, how the center can support the state. I'm sure they can be taken up and be very useful. So, ma'am, one question there was about the monitoring of glutaric acidemia patients. So, if there is a patient with a damage, already there is a neurological damage. So, how do you really monitor the change in dose, or what tests are recommended for monitoring of GA patients, GA1 patients?
The GA1 monitoring is done by periodic evaluation of the urinary excretion of organic acids. And that is the most important test, because sometimes when you do a TMS, the C5DC levels may not show a drastic reduction. It may take quite a long time for the C5DC to come down, but the immediate response that you see is in the urinary excretion. And the other thing that you can do is observe the neurological development. Suppose if the baby without any neurological damage starts showing signs of extrapyramidal symptoms, then you should be very careful and you need to intensify your management.
Thank you, ma'am. So are there any other questions that anyone, any of the panelists or speakers would like to ask? Or okay, thank you so much, ma'am. Thank you for your time. Now, ma'am, if you can stop sharing your screen.
I think basically it is all an issue of organization. You know, all these facilities are there. And I think it's a question of just organizing, putting it all together. And, you know, it's all possible. Because what she has enumerated is possible in every city.
Thank you so much, ma'am. Now we move on to our next panelist, Dr. Shubha, ma'am. Ma'am, as you are working closely in the management and care of patients with hemophilia, thalassemia, please throw some light on the management options, how they have really evolved over the years, and what are the newer therapies and their limitations and utility, and how have support groups come together and making these therapies accessible to patients, and what is the patient psychology about visiting multiple doctors, also known as this provider shopping? How do you think that can be decreased? Thank you, ma'am.
Thank you, Dr. Veronica and Saurabh-ji. Respected Dr. Verma sir, nice to discuss different aspects of rare diseases at this time. And at the same time, I remind that though it's easy to connect online, still I remember I think just before starting Corona, we had a very good meeting of patients and groups. And when they were wearing bright smiles on their faces and bright clothes for the meeting, it was really difficult to recognize them as patients. And I still remember those things. And I hope next time we can have something bright like that. Also, I miss the cycling which we did on the Rare Disease Day a few years ago. Uh, you have asked about hemophilia and thalassemia. So these are the commonest of the rare diseases. First, I would like to say, as Dr. Verma sir said, that these are though so-called grouped under rare disorders. For us who are treating these patients, these are probably even the so-called rare disorders. For us, they are common disorders because we are seeing every day. And what we are discussing today, we are discussing every day throughout the year. And hence, really, to separate them as rare patients and think only on the day of Rare Disease Day by the government is the most important message we need to give to the government, that think of them every day of the year like we are seeing them every day of the year. So this is one thing. And uh, with our experience of thalassemia and hemophilia, as I said, these are commonest of the rare disorders. And as Dr. Verma sir said, India is not a poor country. And that I realize when we have started getting factors of for hemophilia patients, coagulant factors, costing crores of rupees in our refrigerator, and treating the patients in the same way as we are treating, as the patients of hemophilia are treated everywhere in the world. And with the new drugs coming, which are long-acting factors as well as various drugs for inhibitors, which can be given every 3 weekly, and these patients with hemophilia with inhibitors can lead absolutely normal life. All these things are available to our patients. Of course, the story is long, and more than 10 years ago, this government funding for the hemophilia program started. And most important is about 30-40 years ago, the hemophilia patient group started working together. So their struggle was quite long and must be very, very difficult. But the success which they have achieved and we have achieved for our patients with hemophilia and thalassemia makes me feel that though at present every moment we are thinking that rare disease policy is not taking up and it's not properly, like it's only on paper and nothing is happening. But let me assure you that this is definitely going to get to somewhere, because the funds, the government has not really given any funds, but we know that this important first step will definitely lead to further success in next year. I am very, very sure. So all of us working for that, and these our experience with hemophilia is going to definitely have great help. Secondly, what I wanted to say, that the newborn screening, as madam said, that newborn screening is the most important thing which which is very, very cost effective. Newborn screening and prenatal diagnosis are the most cost effective ways. And this rare disease policy as such is not taking care of that, while the RBSK program has newborn screening, and unfortunately it is neglected by the government. In UP, we started newborn screening in 2015 and screened 65,000 babies from the very, very poor patient groups, not coming to the HDPGI, from Barabanki, Raebareli, and so on. And unfortunately, the funding stopped. So such type of phenomena, which is like starting and stopping, and I think we should make more noise to the government for newborn screening, that which may be attached to this rare disease policy, or it can be a separate thing. I will not go into the details of new therapies for hemophilia and thalassemias, but You know, you know that gene therapy is successful for thalassemia as well as hemophilia. And even if that is not at present available to our patients, the drugs which can put them on regular prophylaxis for hemophilia, the patients can lead absolutely normal life, even with inhibitors. Uh, the second important thing you wanted to know about support groups, which I already mentioned, that for hemophilia and thalassemia, like Hemophilia Federation, Thalassemia Federation, as well as Hemophilia Support Group, they are working for more than last 3 to 4 decades. And that's why they could do well. And now these various patient support groups for rare diseases and lysosomal storage diseases are working, have started working, and I'm sure this is going to give show us result in next few years. What we thought, and we are always keep on doing awareness program, and think that lacking of awareness is one important step for problem for these rare diseases. But let me ensure that it's not necessary that first you create awareness and then you start giving treatment. It's other way around, as though the creating awareness and giving treatment are parallel processes. They will go on simultaneously. But if you start getting, if the patients start getting treatment, say for few patients with Gaucher disease or few patients with SMA, the awareness increases so rapidly that it will be like a very, very effective way. So the starting and giving treatment to at least some patients under this rare disease policy during this year of 2022 should be our goal. The numbers may be small, but that will be really very important to possibly bring positivity for patients as well as parents and ourselves. And also it will create a lot of awareness among the pediatricians and doctors who keep on seeing these patients. So I think the awareness will automatically happen. I don't say that we don't need to have these programs for awareness, but awareness very, very rapidly happens if you see some success story. Lastly, Veronica asked me to talk about patients going to different doctors. So this is a story happening every day. It's good and bad, because many times, unless the patient keeps on going to different places, he may not reach the right place or he may not get a right diagnosis. As you know, Fabry disease, the average period from starting symptoms to reaching diagnosis all over world is considered to be 10 to 20 years. And hence, if the patient keeps on going, unless keeps on going in search of diagnosis, or if he doesn't get, because they may be labeled as psychiatric illnesses and so on. So I think this is the one important thing that this happens. This is true. And then secondly, because they do not get the treatment. So that's why also they keep on, like, even if the label is Gaucher disease, but they feel that they didn't get treatment in SGPGI, so they go to AIMS Delhi, from there to Gangaram and so on. So these things keep on happening. And I think that will happen unless we have a really tired system of referral. When SGPGI started, late Dr. S.S. Agrawal, known to everybody, he said that we should have referral in the same way, that no patient will come to SGPGI unless referred by KG Medical College of Lucknow or maybe Medical College of Kanpur and so on. But this did not happen. Ultimately, what happened? They needed referral letter. So what they were doing, going to a small village near SGPGI and used to get some referral note from anybody by paying 10 rupees or 20 rupees. So we do not have that tired referral system, and till this happen, this type of shopping will happen. But now, because of rare disease registry by ICMR, and because we have under our Society of Indian Academy of Medical Genetics, we all are connected. And I think if you keep on making the registry, and because the patients now everybody has got Aadhaar card. So I feel that all medical information linked to Aadhaar card will really help in repeating the patient's investigations, as well as getting the patients going from one place to other. We keep the registry very strongly working, And then if some patient from Lucknow, most of them do go directly to Delhi, and then they say that Lucknow also has some genetics department, so they come back. So naturally, if there is a registry and you put that patient's Aadhaar number and you get the correct diagnosis. So I think linking all patients' data to the Aadhaar card number is the most important thing. And it will be taking long time for everybody's data, like in Finland and Norway, everybody's data, medical data is there. Same way we should have for India, but it may take long time for others to have electronic health records linked to their Aadhaar card. But at least if we do for at least 10 or 15 disorders which are treatable rare disorders, I think that will be one prototype we can show to the country and world, that we can have our all medical data of patients of rare diseases in all over India, whether the patient is in Kerala or here. So I think we have to march for this goal, as well as for newborn screening. So after newborn screening with Aadhaar card, and then probably his all medical records are linked up, and the next generation will have everything of theirs in the electronic health record system. So these are some of the answers. Of course, one can keep on discussing this, and time is no matter, but today time is very important. So maybe if Veronica wants that I have not covered something, please ask, or anybody else has some question.
Veronica, you're on mute.
Veronica, mute her. Veronica, please unmute yourself.
Okay, ma'am, can you hear me? Thank you, ma'am. That was all the information you covered was very important. Just one question that was there in the by the audience, that about the prenatal diagnosis of hemophilia, just your comments. Do you think that it is still relevant in the light of all these newer therapies which give them a very good life?
Excellent question, very pertinent question, because in my talk on genetic counseling and prenatal diagnosis, I show a family where one lady, she has her brother died of say hemophilia intracranial bleed. Her son has maybe 18-year-old handicapped because of chronic knee orthopathy, and she wants that she wants prenatal diagnosis for her daughter's pregnancy, while her other cousin, she has only one son with hemophilia who is 5-year-old and is on prophylactic therapy with free support from government funding, or maybe his father's employer is providing funding, and he is doing absolutely normal. So the approach to prenatal diagnosis of both the ladies will be very different. One younger lady feels that she doesn't feel prenatal diagnosis is necessary for hemophilia. She doesn't feel that the child, if it's detected to have hemophilia in womb, then it should be termination. She doesn't feel justified. So there was a time when I used to feel that inhibitor still is a problem and prenatal diagnosis for hemophilia is justified. But now the new drugs which have come up, they take care of inhibitors so well that even probably this is not. So the things are changing. My perspective has changed. And as you can see, it will be changed. The different families may still have different views, but time has come that probably prenatal diagnosis for hemophilia, there may not be any takers. And even for thalassemia also, gene therapy would be possible immediately after birth, within 3 months of age, and before the patient gets some symptoms. So I think it's a very good time. And though we always feel, and we debate with the Society of Fetal Medicine, that heart in heart, though we do prenatal diagnosis and terminate and consider justified termination, justified for serious disorders like SMA and so on, before 20 weeks. But heart and heart, we always feel that we want something that even if after prenatal diagnosis, we cure the baby in the womb or outside the womb. and termination is very painful process. I always consider it's not really ethical also. So time is not far away where you will not need to terminate patients for prenatal diagnosis of thalassemia, hemophilia, Gaucher disease, SMA, and many, many more disorders. So thanks, whosoever has asked the question. I really want to thank for letting me talk about this area, which is very close to my heart. Termination is really a painful thing for everybody, patient as well as doctor.
Thank you, ma'am. Thank you. We are truly in the era of treatment of this disorder now. Thank you, ma'am. So does anyone else, any speaker or panelist have a question for ma'am? Thank you, ma'am. Now we move forward. Just one question for IC Verma, sir, specifically directed to you. That there is a patient with MPS type 2 and the age of the patient is 3 years and it says the IQ is low. No IQ has been mentioned, and so whether BMT can be recommended therapy for this MPS 2 child having low IQ, as enzyme replacement therapy does not cause the blood-brain barrier. So your views?
Well, I think if the IQ is low, one needs to see how low. And if it's only very mild, there are some people who are doing the BMT for Hunter, but the response is not very good. This the mucopolysaccharide, which accumulates in the brain, is a very large molecule and does not get out of the cell. That is the problem. So I would not really, it depends actually the degree of involvement, of the cognitive involvement.
So for MPS 2 specifically, do you think BMT is advisable in due to lack of published literature?
Well, people have tried and people still try because there is nothing else. But people have tried, but it has not been very successful. Okay. Because I said that molecule which accumulates the gas is so large, it does not get out of the cell.
Thank you so much, sir. Okay. Does anyone else have any comments, or we can move forward now? So now we have Ratna ma'am, and ma'am, I would like to request you to talk upon your views on provision of ERT in the tertiary care hospitals. What are the challenges and what is the role of decentralizing these services? You have always been an advocate of building capacity and providing these ERTs and the different services in smaller cities. And please tell us more about that. Also, being an integral part of the undiagnosed disease program, what are the measures that can be taken the government to further increase the outreach on it? Because as we understand, not everyone knows about this program as well. So ma'am, I'll stop sharing my screen and you can share yours.
Yeah.
Thank you.
So thank you so much, Veronica, for very well thought out questions. And thank you, Saurabh, for taking the cause of rare diseases with so much vigor and vitality, and wishes to everybody on the Rare Disease Day. So the first question was really related to, do we give ERT only in the tertiary care hospitals? And I think that both the questions are linked together. That do we treat patients only in the tertiary care hospitals? And what do we do about building capacity? Now, see, we have been giving ERT for more than a decade now, as are the other hospitals who have been part of the Compassionate Access Program. And that was the first exposure to actually treating genetic disorders beyond thalassemia and hemophilia, which I did as a part of my training in SGPGI. Now, when it came to giving ERT, the first time, it was even before the Compassionate Access Program started, and we had to start for a patient with MPS 1. The package insert was all that we had. We did not have an office of the company in India. We were communicating with somebody in Hong Kong, and this was obviously through Sir. It was all initiated by Sir. And And the package insert said that when we give alburazime, this was for a patient of MPS 1, we put in 10 ml of albumin. And we didn't know anything. I mean, I didn't know. We had to get a 500 ml bottle of albumin, take out 10 ml and put it into the enzyme. So the first time we did that, but we wondered that every week, are we going to do that? Are we going to waste so much of albumin? Are we going to get the patient to spend so much money? Because everything in India is an out-of-pocket expenditure to a large extent, whether it is in a public hospital or it's in a private hospital. And that's then when we started talking to people, we started finding out, and they said, no, you don't need to do that. So we started from there. Then came the group, the IMAP group, where we had experts within these lysosomal storage disorders from other countries who had been dealing with all this, who had really been pioneers in developing these enzymes. And I think that it's only over the last so many years that we've developed immense experience and expertise in treating these patients. And I truly believe I'm actually an exponent of that because we have been in centers and we've had the privilege to learn these, we need to develop capacity and we need to train the younger generation as to how to take this forward. How we say that they must be motivated in learning about rare disorders, in being able to diagnose patients, because we know that everywhere early diagnosis is equal to good treatment outcomes. There's no point in developing extensive contractures, in becoming very sick, and then taking forward therapy. The same is for LSTs, the same is for any other disorder that we want to treat. So how are we going to get these people interested? The concept is that if they're going to look at a patient and say, oh, I don't know what I'm dealing with, let me refer it, they're never going to identify a second patient who comes to them with similar phenotypes. So therefore, what we do for our LSTs is, and what I have been practicing for many years now is, we've made the diagnosis, we've initiated the treatment, no matter what the disorder is, and then we get back to where the patient is staying. The aim of giving treatment to a patient with a rare disorder is to improve the quality of life. How is the quality of life going to improve if I'm going to tell the patient, you come in even 20 kilometers every week or 200 kilometers every week, lifelong, to get the drug? You're going to be admitted. You have to be admitted for a day and then you go back. I believe now that there are rules that the admission has to be overnight. The patient says, I don't want to go back there. Ma'am, please tell me another place where I can go and get the therapy. So what we did was that we identified the local doctor, the primary care physician, who was where the patient is. And we have trained the person, we have given the protocols. Of course, after giving the first few enzyme replacement therapies in our hospital, so that we are sure that the child has taken it well, etc. Though, of course, reactions can happen anytime. That is why you have to be in touch with the family and with the primary care physician. And things are happening well. So the second time, so the physician is motivated. He's seeing the change because of the therapy. He's seeing the change because of a diagnosis that was made. And therefore, the physician gets interested. And that is how he generates an interest for rare disorders. He finds out, how am I going to diagnose them? How am I going to further manage them? And what are the phenotypes that I need to look into? And what I really want to show is, there were just 2 slides that I want to show. One was the transformative therapies that we have. This is at the outset, and these are 3 patients of Gaucher disease. We have engineers, we have doctors, we have people who have done MBA. He's probably done his MBA, and they are all now advocates. He's an adult now, but these are young. This boy plays the tabla, and this girl, though she is type 3, she's got a little bit of oculomotor apraxia, but she's still doing very well. She barely speaks Hindi. She's from Bengal, but in Bengali, she will come and she will do a lot of activities and actions when she comes in once a year. So we encourage them to follow up with their local physicians. We call them once in 6 months and once a year to ensure that things are well, and go back to the doctor as to how the outcomes are. Now, this is an adult with MPS 1. He's the milder phenotype, the Hurler she spectrum. He's a drummer. He makes advertisements, which are real big time advertisements. He works with big companies. And this is a young boy again. So this is giving life to these patients who otherwise would have been so incapacitated that they would not have really been able to achieve anything. And I think that, to me as a doctor dealing to a large extent with diseases which don't have good outcomes, we don't give a lot of good news all the time. In fact, today morning only, I was talking to a family where the child has been diagnosed to have PCAN. And it's, he's all over the place. Can I do Ayurveda? Can I do this? I'm seeing my child going down. So when we have transformative therapies which can give a new life, I think that we need to work hard to make these therapies available to the patients. I don't say that we treat anybody and everybody. We know with our experience that which is the group of patients whom it helps, and therefore it helps taking that forward. And so I think that's about, should it only be in the tertiary care centers? I think till we have been able to train the peripheries, we initiate it here, but to be able to train them and to interest them, we take it to the periphery. See, I feel that the doctors in the peripheries are not, they are not the ones who come into meetings to understand how do we diagnose a genetic disorder. They will remain rare until we make them aware. We need to go to them. And how do we go to them? Is we go back to them with their patients. And I think that works really well. It's tedious. I know it's tedious, but if we are able to interest one person in the periphery, then through that person, we can get collective people within that society and then train them beyond. So that is how I feel we need to impart education. Of course, until we have it a part of our curriculum and we make it mandatory in the exam, that is only how people are going to really learn something about genetics. And the last is about the undiagnosed disease program. And I will just, so I think I've more or less completed all this. And the last is about this undiagnosed diseases program. This is an ICMR funded project. And there are 3 centers you can see below: Gangaram Hospital, CDFT and Nizam, and Sanjay Gandhi Postgraduate Institute. Now, the whole aim, so what is different about this program? The program is all about looking at rare disorders with a different eye. It's not a program where we just get in patients to do free genomic testing. That was not the aim of the program. The aim of the program was to get in undiagnosed patients. That means we know that they are genetic. They've undergone some sort of genomic testing, maybe an exome or a clinical exome, and we don't have a diagnosis. And then we include them into this program. And we work with a multidisciplinary team, because I cannot be a cardiologist and a neurologist and a rheumatologist. So depending upon what the phenotype of the patient is, we involve other specialities. We work on a common platform. Like currently we are working in my hospital. And actually that's what we want to encourage. A child who looks like, who has dysmorphism, has a trio exome which tells us that it could be Rubinstein-Thebe. The child has hematological abnormalities of thrombocytopenia, of some schistocytosis, etc. And there are other things that have come out in the exome which was done elsewhere. So we have the kidney, we have the hematology, we have the clinical hematology, the lab hematology, and the genetics who are working together to solve the puzzle of that patient. And I think that is what is very important for rare diseases. We've done it for a couple of patients before. And then we work amidst the group within this, present our cases. So I could have seen something and have an idea about a rare undiagnosed patient which is there in another center, because they are not so common. And then we go forward with genomic sequencing. What we've done within this platform is we've made common phenotype data capture software. We've created a common pipeline to analyze exome and genome data. And we are trying to standardize copy number variation analysis within that. So there are many heads working together, and I encourage you to participate in this. You can, there are patient enrollment forms. You can see that at the bottom here. This is an email which you can send. And please, if you have an undiagnosed patient, we accept patients from outside, but of course they would have to, fulfill the inclusion criteria. You can submit the details within this, and we will discuss that and then come back to you. You can submit it online. You can submit it on the email that is provided, that is looked at by all the centers. So that's what I have to say about this.
Thank you, ma'am. Thank you so much. I'm sure everyone is now aware of the UNDP program. And ma'am, maybe you can just keep sharing the slide if someone wants to copy the email. And there is one question, ma'am, in the chat box for you that please let us know about the clinical trials and therapies that are available at your center and which children can be sent for those.
So the first thing that I would like to tell everybody is the ICMR registry. It is available. It's the registry for a large number of some disorders, most of them that have treatment, the small molecule disorders, which of amino acid, carbohydrate, and fat. It is for the large molecule disorders. It is for skeletal dysplasias. It is for the lysosomal storage disorders, and it is for thalassemia, hemophilia, and what have I left out? And the neuromuscular disorders, DMD and SMA. It is on the ICMR website, and there are many centers. There are about 25 centers who are participating in this registry. So I think we are asking the government to support awareness, to support diagnosis, to support treatment. The government needs to know how many patients there are. So first, I would request everybody to at least participate, to go to the nearest center that you have close to you and enroll yourself in the registry. The second thing is the trials that are happening. We have a trial currently. There's going to be a trial on SMA, spinal muscular atrophy, and this is related to intrathecal gene therapy. This is for patients from 2 to 18 years of age and SMA type 2. That is what we have currently. And as of now, it's only this trial.
Okay. Thank you, ma'am. Thank you so much. Do we have any other questions for Ratna?
We would also have one for DMD for the exon skipping, but we have ethics clearance for that, but the protocol is now, it'll start in a little while also.
SMA, what about SMA?
So SMA, I've said the SMA gene therapy trial.
Dr. Ratna.
Hanji, ma'am.
As you said, that treatment. Enzyme.
Sorry?
Hello?
Yes, ma'am.
The enzyme replacement therapy can be taken to the peripheries, and we also promoted this, and some of my patients are taking under the guidance even in remote villages, and they keep coming for follow-up every 3 months, and so they need not come to the tertiary care centers for the enzyme replacement therapy. So this
yes,
also we are planning, and we are quite successful with that.
Yes, ma'am. I know it really works well, and it really interests the local physician, the primary physician,
right.
Finds it nice.
Physicians feel so happy that we are giving such an expensive drug in our hospital. And they take all the care and then take care of the patient quite well.
Yes.
And
yes.
the other question I just would like to know, maybe from other people also. See, one of my Gaucher patient who is on ERT developed liver ascites. And then he had multiple mesenteric lymph nodes. And he is on ART for the last almost 7 years. And now there is ascites. And this ascites look like a transudate. It's not inflammatory. And it is milky. And then when we did the triglycerides, it is quite normal. So what is your experience in a case like this? And how do we go about it?
Ma'am, in this case, we'll have to start from seeing whether there is cirrhosis. So what does the ultrasound tell us?
Ultrasound wise, there is no evidence of any altered ecostructure.
So what is the reason for that ascites? Has an endoscopy been done? I mean, if the liver is absolutely normal and there is no cirrhosis and there are no varices also to tell us, then it is interesting. I mean, could it be any alternative pathology? Could we be dealing with tuberculosis?
No, tuberculosis we have ruled out. We did the PCR, the ascitic fluid, but the ascitic fluid is milky. It's not like a straw-colored fluid.
There are any big lymph nodes in the abdomen?
No, sir. He had mesenteric, earlier he had mesenteric adenitis, but now he doesn't have.
Ma'am, maybe we can think about it and discuss it offline then.
Yeah.
I'll be in touch with you, ma'am.
Okay.
Okay, ma'am, Ashok Velodi sir has a question for you, Ratna ma'am. So the question is the UDP linked to the Undiagnosed Disease Network International?
Yes, it is. Yes, it is. We are a member of the Undiagnosed Diseases Network International, and it is linked to that program. So linked in the sense we are a part of the program, but every program within that is individual. They don't provide any funding. The funding has been provided by the Indian Council of Medical Research. But yes, for any kind of knowledge, information, support, questions, we are, the UDNI is there.
Okay, thank you, ma'am. Thank you so much for your time. Now we'll move on to our next speaker, and Dr. Ashok Gupta, sir. Sir, are you here?
Yeah, I'm here.
Good evening, sir. Sir, so you have established an excellent center for rare disease in the regional center. What is your experience and what messages do you want to give to doctors who plan something like this to establish centers at non-metropolitan cities? And also, there is a routine diagnostic ODC for genetic disorders. What do you suggest to minimize it? What is the role of early screening in diagnosis of rare disorders? And is there a need to prioritize the orphan drug policy? And what, according to you, is the future for children with rare disorders in India?
Thank you, Veronica, for really running the session so very well. And at the outset, I'd like to express my thanks to Saurabh, who's been instrumental in really bringing about the issue of Disease India Foundation. And so to begin with, because we are a regional center and regional center based out of Jaipur, and because almost 9-10 years back, we had some patients who really made us think very seriously on the mistakes that we have made. And the point was, at that point of time, we had a patient. At that point, we had a patient with massive splenomegaly and bicytopenia, was not improving on treatment, and we thought it was hypersplenism, got a splenectomy done, and still the patient did not improve. And so that was one of the thoughts that came to us. We are making some mistake. And then we had some newborn babies who died, and we couldn't save them. We were treating them as clinical sepsis. And all these things really brought a thought into us that we are making some mistake in the diagnosis. And that's where we got into the development of a rare disease program at Jaipur JKLon Hospital. It is a government-owned institute. We are one of the biggest pediatric hospital in the country with a bed strength of 1,000 beds. We have 200 bedded NICU, 200 bedded PICU. So fairly big, and we have a fairly big patient footfall in the institute. And so at that point of time, because this was a thought, and then we started working on developing a team. And we decided that, yes, the team has to have somebody who is good at newborn screening, somebody who's good at metabolic disorders, and somebody who's good at genetics, and then physiotherapy and all that. So we brought in, at least I was at that point of time the focal person. I brought in all these people. We developed a team, and we also realized at that point of time that, yes, because at that point of time, most of the issues of rare diseases were being handled by geneticists, and there was a big delay in the diagnosis. For example, when we had a splenectomy, and this patient was subsequently diagnosed as Gaucher, it was almost 7-8 years lost. And this was because we referred the patient late to the geneticist. And that made me think, yes, I think we should have the pediatricians and the primary care physicians understand what a rare disease is, how does it look like, and how do we go about it. And that is exactly what has been identified by even Dr. Ratnapuri when she said, yes, you have to go back. The way that she says is that you have a patient who can be taken back and made, the doctor can be made to understand. And so here I thought that, yes, if the pediatricians and the primary care physicians can be sensitized, we'll be able to pick up the red flags early, send these patients to the geneticist at an appropriate time, so that an early diagnosis, which is very crucial for these patients to do well. So with this, we started working on it. And today, I'm just like to share that, yes, we have completed more than 50 publications from our group on rare diseases. We've done 3 books. Two of them are the textbooks on rare disease, and one of them has been the Atlas of Rare Disease. And this morning, one of my students completed her dissertation on the clinical epidemiological presentation of rare disease patients in the last 1 year, and we covered 160 patients. So from a non-descript institute in the field of rare disease in the last 8 years, we have had a big newborn screening program. We have covered almost 35,000 newborn babies and diagnosed a large number of easily treated. So we've been able to, with the newborn screening program, we've been able to identify a large number of cases of congenital adrenal hyperplasia, G6PD deficiency, hypothyroidism. And so this has been a very satisfying movement. And then we have had the SMA gene therapy being done here. So we have had a fairly long, in the last 8-9 years, it's been a rewarding experience. And why I'm trying to say is that just yesterday, we had a discussion on the centers of excellence. I said the term center of excellence has really affected some of us in the regional areas, because people now believe that there is only these centers which can do treatment. Even the government in my own state has started reacting that no, these patients have to go to the centers of excellence. You cannot treat them here. And even in the court, the government is given that in writing that we cannot treat these patients because we do not have a center of excellence. So one of the notions that I gave yesterday was to give them a new terminology. You have national centers and you have regional centers, so that the question, the confusion with the patient can be really done away. So that is the kind of experience that we've had. We've been able to train almost 250 pediatricians so far. And we have been able to also politically and socially influence the government in trying to understand, yes, there is an issue of rare disease which has to be understood. So my thought and message is that, yes, this rare disease group has to work in close coordination with pediatricians at large, because this is one community which we have almost 30,000 members all over the country. And so if this group gets sensitized, I think you will have a big chunk of people who are now able to pick up the patients early and send them there. Then the question of the orphan drug policy that you raised, something good about that is the orphan drugs have been defined by the new Drugs and Clinical Trial Rules 2019. And these, what has been said is these are the drugs intended to treat a condition which affects not more than 5 lakh population in the country. And we have the CDSO as the regulatory agency. And something good, there is no application fee required for conducting these clinical trials. And there are mechanisms to expedite the pathways also. So you have a lot of good things happening. And the role of screening has already been identified. Everybody understands that screening certainly helps you pick up patients early. There will be a stepwise approach in getting up the newborn screening program and the other screening programs for diagnosis of the rare disease. And finally, if you have the point that you have raised is the future of children with rare disorders in India, I think in the last 8 years that we have seen, we've really moved a lot of distance, and we have now have a lot of patient groups who are proactive. There is a lot of pressure on the government, a lot of pressure on the system to perform, and to the extent that even in our own state, the chief minister has announced a package of 10 lakh rupees for any patient who means the kind of money that could be spent for treatment or diagnosis of any individual patient. So there are major developments that are taking place. More and more of the transplant programs are coming into place, and more drugs are becoming more easily accessible through the drugs and clinical trial rules of the year 2019. So I think there is a tremendous good future coming up for all these patients. Thank you.
Thank you so much, sir. I would like to congratulate you on the tremendous work that you've done. It is really heart-wrenching to see that there has been so much progress in the book chapters and the training programs that you've been assisting with. So this is congratulations again. So there are some questions actually in the chat box repeatedly about Friedreich's ataxia actually. So if any of the panelists would want to talk about any newer therapies in Friedreich's ataxia or any newer things that you people are trying at your own centers.
No, we have, at least my center doesn't have any specific treatment trial on Friedreich's ataxia.
So I know that there are certain trials on methylprednisolone and rosuvastatin which have been completed, and a certain ongoing on resveratrol, but I also don't think no trial is there right now in India for Friedreich's ataxia. So thank you so much, sir, for your time. And now we move on to our next speaker, Dr. Priyanshu. So, Dr. Priyanshu, what is your experience with rare disease management, and highlight certain challenges and what have you done to overcome those? And why do you think India's research is lacking as compared to the West? And do you think that all the guidelines that are being followed in the West, can we really follow them to really combine and get to the registry, or to get a natural history of diseases in that way? And how the basic sciences can be developed further in order to have our own trials and have our own pharmacotherapies for rare disease drugs?
Thank you, Dr. Veronica, and thank you, Saurabh and RDIF for inviting me on today's panel discussion. So your first question, Veronica, is what is our experiences with rare disease management? So I just want to tell you that we are having a tertiary care institute, and we are having almost more than 30 to 50 rare disease patients per month. So we are getting all sorts of rare disease or genetic patients. So whenever we are diagnosing any patient, so first we are finding it's very difficult whether first we are looking for any drug, whether it's available or not. So in most of the cases, we are finding that there is no approved drug is available. For a few of the disorders, such as lysosomal storage disorder, is small molecule inborn error of metabolism, and some neuromuscular disorders such as spinal muscular atrophy, we are having few treatment options available, but it is really difficult for families to afford these medications. And for few disorders, we are having some clinical trial option. And whenever we are offering patients about the clinical trial, so it is seen that now patients are more sensitized towards the clinical trials also, and they agree to become part of it. Then we are trying to overcome these challenges with the collaborations and with the charitable access program, compassionate use program, managed access programs, and including these patients in trials. Then the second question is what we think about research in India. So definitely the research in India is lacking, far behind as compared to the Western world or developing countries. I had spent 1 year in US. I know that we are very, very far behind as compared to US. So there are very few natural history studies which are done in India. The foremost point we are lacking in research is because of the non-availability of research grants. There are very few grants, very few researchers are getting grants by DBT or ICMR as compared to Western world. So we need to increase the research grants. And second important point, during our education or MBBS time, we don't have any exposure to the research. So that time we should have a protocol for research also, so that the undergraduates can be sensitized for research. And the companies, pharmaceutical companies in India, they should take a lead, and they should strengthen the research part so that we can develop indigenous molecule to treat these patients. And basic sciences needs to be developed further. And these basic scientists, they should collaborate with the clinicians, and they should understand what is the need for these rare disease patient and genetic disorder patient, so that we can further have a good outcome. Thank you.
Thank you so much. Thank you so much, Priyanshu, for your answer. So there is a question. I will just, which has been directly posted. I'll just write it out for you. You can just read it. So can you see the question, Dr. Priyanshu? Can you see it?
Yes. So the question is, do you think, just a minute, I lost the question. Do you think there is a gap between Government of India and Center of Excellence when it comes to funding? Should Center of Excellence be also proactive and engage with Government of India to provide funds once the name is entered in the portal? Will entering name in the portal is the job of Center of Excellence? Okay. So, right. So currently, as Madhulika ma'am already told us that the policy is developed, but in this policy, government has not dedicated funds. The funding is to only in the group 1 of disorder, they are giving funds to Rashtriya Arogya Nidhi. But for group 3 disorders, they mentioned that the fund should be generated through crowdfunding platform. But the crowdfunding platform, we are not getting enough funds till now. But in future, probably we will get better funding. And the second part is to enter the name in the portal. So the name in the portal can be entered through the Center of Excellence. So any center, they can collaborate with Center of Excellence and they can enter the name into the portal.
Thank you so much, Dr. Priyanshu. Is there any other question for Dr. Priyanshu? So this brings us to the end of a fantastic panel where we heard perspectives of the leading geneticists and pediatricians of India. And I hope that this answered a lot of questions by a lot of raised by a lot of people. It personally helped me learn a lot also. So I do thank each and every one of you for taking out time and being a part of this panel. Thank you so much. And with this, we now move on to a little talk by Anil sir, who's a general manager, specialty care business unit of Sanofi France. He's based out of Delhi, and he joined Genzyme in 2017 as the director and led the launch of key specialty care products in renal and orthopedic space. Since 2007, he has played a key role in the development of rare diseases ecosystem in India and has been closely involved in spearheading key company initiative and collaborations with multiple external stakeholders during public and private institutions and organizations. He has also worked across sectors in companies like Escorts Trackers Limited, Larsen Tobacco, Ranbaxy Laboratories, and Reddy, spanning manufacturing, sourcing, business development, planning, sales, and marketing, etc. He's a mechanical engineer from National Institute of Technology, Kurukshetra, and MB International Business and Institute of Foreign Trade, New Delhi. So my question to you, sir, is about the rare disease ecosystem that has been for which Genzyme has been a part, and you have also been instrumental in developing that. Please share your experience about the rare disease ecosystem, sir.
Thank you, Veronica, and thank you, Saurabh, for inviting me to the meeting today. It's been a real pleasure listening to all the talks. Very, very informative. And as you said, Veronica, I also learned quite a bit, even though I'm not from this particular profession as such. As I look back, we are in 2022. The first Rare Disease Day in India was commemorated in 2010. And the theme of that Rare Disease Day was making rare diseases a public health priority in India. I think we're still not there, but we have moved a lot of steps in that direction. From one single meeting which took place in Gangaram Hospital, which had around 100 odd attendees, in the last 2-3 years, I have been seeing that there have been multiple meetings, and even this year, even today, I'm sure there would have been something like 8 to 10 meetings across the country commemorating the Rare Disease Day, which is, I think, a big step forward for a country like ours, where rare diseases were literally unheard of 14-15 years back. There were very few select people who knew about rare diseases those days. I have a small presentation which I'll share with you. I'll not take much time because a lot has already been said in this particular space. Just. Is the presentation visible?
Yes.
Yes, yes.
We've already heard that the number of rare diseases is estimated to be around 7,000 odd numbers. Individually, they are rare, but collectively, the number is large, around 300 to 400 million globally. The estimates vary from publication to publication, and I'm sure the numbers go up every year. But one point that we have to definitely keep in mind here is that the actual number of patients diagnosed is very low compared to the estimated prevalence. These are often chronic, progressive, and have a very poor quality of life as a result of that. And almost 80% have genetic origins, and 30% patients do not survive beyond the age of 5. When we look at the number of diseases that can be treated, it's only around 5% to 6% of diseases that still have a treatment option. And these drugs are known as orphan drugs. The definition varies from country to country. And as Dr. Ashok Gupta mentioned, in India, just a couple of years back, the CDSCO also had a definition for us, which is not more than orphan drugs are meant for treating diseases which do not have more than 500,000 patients in India. So while we do talk about having a definition for rare diseases, at least the CDSCO has taken a step forward and come up with a definition for orphan drugs. When we look at the key milestones in the last 30 years, globally as well as in India, and a lot of it would be essentially limited to my experience in the space of LSD, so please pardon that. But when we look at the start, it all started really with the passage of the Orphan Drug Act in the US in 1983. Before that, while there were some drugs for rare diseases which had been developed, but not much was being done in the field of rare diseases, and hence it was felt that there should be an Orphan Disease Act or an Orphan Drug Act, so that more emphasis would be given on finding treatments for rare disorders. And that is why the name was also, the Orphan Drug Act. what happened in between, and here I'm talking more from a Genzyme perspective, that Genzyme was founded in 1981, and we started working in this space sometime around the mid-80s in the field of rare disease. And in 1991, we launched Ceridase, which is essentially a placenta-based enzyme replacement therapy for the treatment of Gaucher disease. And I would say are amongst the pioneers in the field of rare diseases in terms of developing the ecosystem at a global level itself. We started with the US and went into other markets one by one. Along with the launch of Ceridase in 1991, we also launched our humanitarian program because the cost of medicines was extremely high. The cost of Ceridase itself was very high, and it is a chronic therapy, has to be taken for life. We followed it up with our recombinant version in 1994, but the point was that since we felt that access would be a challenge for patients across the world, including the US at that point of time, because of limited access alternatives, we started our humanitarian program. In fact, last year we completed 30 years of our humanitarian program, as well as the launch of Ceridase. In 1991, we started our humanitarian program in India. And that happened because there's a family from Mumbai who approached us. And their son was diagnosed with Gaucher disease. And they were looking for an option for treatment. And they got to know that there's a company in the US, in Boston, that makes a medicine for this particular disease. They wanted to purchase the medicine from us. We knew that it would not be economically feasible for them to purchase the medicine. And as a result of that, the first patients in India started receiving the therapy from our company, totally free of cost under our humanitarian program. Dr. Ratna mentioned about this patient in her presentation. He's a young man in his mid-20s, and he's working in an IT firm. And when you look at him, you can never say that he's suffering from such a dreaded disease. In 2007, we incorporated Genzyme in India. And at that time, we started an India-specific charitable access program for 4 of our LSD treatments. And we also founded the India Medical Advisory Board, which comprised all the eminent geneticists in the country at that point of time. And we also, in 2008, supported the launch of genetic clinics that Dr. Shubha referred to during her presentation. And this was a big step, for a small step, but I think the intent was that it would become a big thing going forward. And I think that is what it has become now. Small step, but leading to a big outcome. In 2010, as I mentioned, the first Rare Disease Day in India was commemorated in Gangaram Hospital. And in the same year, the RD task force was also announced by the ICMR. In 2013, we launched our diagnostic program, Disha. Almost 6,000 samples have been tested as of date. This is a free diagnostic service for testing some of the lysosomal storage disorders. And we have been collaborating with different hospitals and institutes across the country to do that. We also launched the Fellowship in Clinical Genetics. In association with SIMG, we have been supporting this for the last 9 years now. And almost 60 physicians have benefited from this 3-month-long fellowship program, which is conducted across the country in different hospitals, or I would say in a way, the centers of excellence, even though officially they may still not have been declared as the centers of excellence.
Hello.
Yeah. In 2014, the first South Asia LSD Symposium was organized in collaboration with ISIM. And the first Gaucher Day was also commemorated in India in 2014. We supported that. Even before it was formally announced, the LSDSS organized the Gaucher Day in India. In 2016, a key event which happened, and I would say that's a milestone, that Karnataka became the first state to offer therapy for select rare diseases in the country. And in 2017, the National Policy for Treatment of Rare Diseases was announced. Dr. Madhulika talked about it, that in 2018, the policy was put on hold because of certain logistical issues that needed to be managed. And we talked about the orphan drug definition by the DCJ in 2019. And in 2021, the National Policy for Rare Diseases was announced. It talked about the formation of COEs and also the launch of crowdfunding portal, which today has almost 240 patients uploaded on the portal. Big step forward. We now have to see what will happen as we move ahead. What also happened was that in our charitable access program, from the first patient in 1999, there are close to 130 patients who are getting therapy. And many of these patients have been getting therapy for almost 10 to 15 years now. And that has had an immense impact on the quality of life of many of these patients, and many of them are leading near to normal lives. And just try to capture whatever we have done, not full, at least some part of it in terms of awareness, diagnosis, the access part, as such, the partnerships that we've had with patient societies, the ad posts that we have done, the preceptorship programs that we've had, not only with SIMG, but also with IGIB. And the capacity building work that we've done in the field of diagnostics, which was with NIMHANS and with GBPAN. And the centers of excellence that we've helped develop in the country, both in the government hospitals as well as in the private hospitals. When I look at this, there are certain key takeaways and the next steps that we have to look at. There has been a considerable progress in increasing the awareness of rare diseases in our country. We have moved a long way from where we were many years back. And we have also ramped up our diagnostic capacity in the country and capabilities in the country, in both the private sector as well as in the government sector. The states, some of the states at least, and reimbursable institutions like you have the ESIC, the armed forces, certain public sector undertakings, CGHS, they have started offering, or at least they take care of the patients who are under their ambit and support them if they have a rare disease. So that change has also happened over the last 9-10 years. And of course, we know that the National Policy for Rare Diseases has been announced in 2021. It is extremely important that, that patients who have been identified for treatment, the treatment should now start. And that is how we'll see the success of the policy, because that will help in also developing the other parts associated with the policy, which are related to awareness and diagnosis as well. And as Dr. Verma said, let's work together and get something going. And as I had my presentation, I would just like to share the story of a young boy, or I would say a young adult, who's now been selected in the under-16 cricket team of Karnataka. The story of Prajwal. And with this, I will end my presentation.
Gaucher is a rare genetic disorder that causes enlargement of the liver or spleen, bone abnormalities, and blood disorders.
My name is Vanita Huluraya. We are from Bangalore. We have 2 kids, Pankaj and Prajwal. My elder son Prajwal is 13 years old. He has Gaucher disease. And once we go to hospital, the doctor told the spleen has enlarged. You have to admit the child. His stomach was too large. For 3 months, we were in the hospital for diagnosis. Finally, stomach and bone marrow biopsy has done for Prajwal, and they diagnosed as a Gaucher disease. And finally, we got the medicine for Prajwal. And after that, therapy has started. By taking ERT, the stomach was normal, the blood count was normal, his growth was also normal, and is a healthy baby now.
I love cricket. When I grow up, I want to become a cricketer.
Early treatment gives patients hope when they think they have none.
Thank you.
Thank you so much, sir. There is so much that you and Sanofi have contributed to the care of children with rare disorders. We are very thankful for everything and the great journey that has been. And the last video was very inspirational. And as we know that although the disorders may be rare, but the care should be not. Thank you. And last but not the least, I would like to invite Mr. Prabhat Ranjan Dean, who's a very senior and popular journalist, and to share his views and tell what is going on that side of the media about rare disorders. Please, Mr. Prabhat.
Hello.
Mr. Prabhat, are you here?
Yes, I am hearing you. You are getting my voice or not?
Yes, we are getting your voice, but we are not getting your video.
Just a moment. I'm not that much. just hold on.
Yeah, that's okay. If you don't want to put your video on, maybe you can just speak.
No, there is no any objection in having video, but I'm just hold on. You can say yes. Now, okay. I am Prabhat Ranjan Dean, and namaskar to you all. Are you getting my voice? Please confirm.
Yes, namaskar, sir. Yes, sir.
So, first thing is that this is a moment of pride for me that Saurav Singh has just invited me to join you all. And I'm afraid I'm at the moment out of a station and I'm in Hyderabad. And I have just taken 2 minutes from my chairman because I was in the meeting. And I'm just conveying my regards and thanks and the best wishes to the organization created by Saurav Singh. And as I said, that this is a moment of pride for me that I am also included in your organization. Your field on which you are discussing, and many experts are there. So I am not one of them. I am a journalist, and I can assure Saurav Singh and the organization that you have taken a great initiative to help those who are facing such rare diseases. So I am conveying and I am just saluting you for your great initiative. And simultaneously, I am giving you word as a journalist and on behalf of my newspaper also that we are with you. Whatever you will seek, any support from me as an individual journalist or from my organization, I will be, or my organization will be with you all. So this is my duty to inform you that I am looking after UP, Uttarakhand, Bihar of Daily Excelsior English Daily that is publishing from Jammu and Kashmir and Ladakh, and also looking after the 3 newspaper publishing from Hyderabad and Bangalore, Daily Citizens Evening, Telugu Daily Dhwani, and Hindi Daily Shubh. This is all I am saying because I am saying you that these organizations are with you. I am giving you my words. So I am just summing up my thoughts because I have to rush in my meeting with the chairman. So please pardon me, but thank you so much, and I again salute you all. So should I leave now?
Yeah.
Thank you so much. Thank you so much, Mr. Prabhat. We are very thankful for your support, and we'll reach out to you whenever necessary. Thank you so much, sir. You can leave if you want to. Thank you.
Thank you. Thank you. Right.
Thank you. So as we come to the end of the program, and we're already quite ahead of time. So now I would like to invite Saurabh to give a vote of thanks, and then maybe we can end the program. Thank you. Mr. Saurabh, do you want to give the vote of thanks? Thank you.
Yeah, thank you all the respected speakers who delivered their brilliant speech today on Rare Disease Awareness Event, National Symposium 2022, Care for Rare. I wholeheartedly thank our all entire team who supported us, and the keynote speaker, Honorable Minister of Jharkhand, Shri Banna Gupta ji, and the Member of Parliament, Honorable Ajay Nishad ji, who could not participate in this meeting due to his parliament session was going on. So I also welcome our panelists, Dr. I.C. Verma, Dr. Madhulika Kabra, Dr. Ratna Radharama Devi, Dr. Ratna Puri, Dr. Sudha Fadke, Dr. Ashok Gupta, and Dr. Priyanshu Mathur. And also our speaker, Mr. Anil Raina, Mr. Prabhat Ranjan Deen. I also thank our moderator, Dr. Veronica Arora, for her wonderful moderation today. Again, thank you so much for all your precious time today. If time is money, then today we have earned $1 million. Thank you so much.
Thank you, Saurabh. Thank you, everyone. Good night. And happy Rare Disease Day.
Happy Rare Disease Day.
Sir, sorry to disturb you. Just got one more question from our audience. So, ma'am, I am texting you. Please check out.
Okay. Okay. So the question says, we still need an effective rare disease policy, as making crowdfunding portal will not solve the problem in view of large number of cases. And even in the last 6 months, we have just raised 1 lakh. Does Government of India need to be more innovative in policy making? That is a very difficult question. So does Government of India need to be more innovative? So anyone can take that question. Sir, do you want to take that question?
I think you will see a change in the next few months. Fortunately, in the ministry, the people also keep changing. So the new batch, which a group is there, is very, very supportive. So we hope to see a big change in the coming months.
Thank you. Thank you, everyone. Happy Rare Disease Day, and hope to see you all soon in person. Good night.
Thank you. Thank you, all of you.
And thank you, ma'am. Good night.